to WashU's Love Data Week keynote session. I'm Nancy Miller. I'm the Associate Provost for Institutional Effectiveness, and I'm really delighted to be with you today. Back in my public health researcher days, when I had fewer meetings and more time with data, I was in a room with colleagues, and we were looking at the same set of data on how well community needs were being met in St. Louis. On the surface, the data suggested things were improving, but as we dug deeper into the data and looked at it more closely, different stories were emerging. Some saw evidence of progress, others saw persistent gaps, and some of us noticed that whole experiences weren't showing up in the data at all. That moment has stayed with me and continues to guide my work ever since, because it reminded me that data doesn't speak for itself, people do. And the questions we ask and the values we bring shape what we see and what we do next. And that's what Love Data Week is really about. It's an invitation to step back and reflect not just on what the data shows, but on how it's collected, interpreted, communicated, and used responsibly. And when we do that well, data becomes a tool for better decisions, not just better answers. So I know for my team in the Office of Institutional Effectiveness, this is about stewarding data in ways that are responsible, reflective, and grounded in the real experience behind the numbers. And I know that we're not alone in that. All of you and our partners share that same commitment, using data thoughtfully and collaboratively and in service of meaningful impact. So I just want to take a moment to thank our partners who helped make Love Data Week come to fruition. The Becker Medical Library, the Brown School Library, the Data for Social Impact, the Digital Intelligence and Innovation Accelerator, the Institute for Informatics, Data Science, and Biostatistics, the Office of the Vice Chancellor for Research, the School of Continuing and Professional Studies, the School of Public Health, the Graduate Center, the WashU Libraries, and my team in the Office of Institutional Effectiveness. So thank you all for your collaboration and for creating space for our WashU community to come together this week and really think about data and how we work together to make it more meaningful for all of us. So now it's my pleasure to introduce today's keynote speaker. We're honored to welcome Sandro Galea, the inaugural Margaret C. Ryan Dean of WashU School of Public Health, the Eugene S. and Constance Kahn Distinguished Professor in Public Health, and the Vice Provost for Interdisciplinary Initiatives. Sandro is a physician, a population health scientist, and one of the leading voices globally on how social, economic, and structural forces shape health and well-being. Through his scholarship, his leadership, and his public engagement, he has helped redefine how the field of public health understands responsibility, evidence, and impact. In his keynote today, Sandro will invite us to consider how data can better human flourishing and how we connect evidence to meaningful action. So please join me in welcoming Sandro Galea.
Thank you, Nancy. And thank you all for being here this Tuesday afternoon. I was delighted to be invited to speak at Love Data Week, because what better name is there for a week than Love Data Week? And I was even more delighted when I realized I was actually speaking in like this courtroom. I'm just a doctor, so like this is like super cool. So it's great to be here. So thank you all for coming. I'm going to talk a little bit about data from a health perspective, and which is what I was asked to do. Am I echoing, or is this okay? Good. Okay. I'm going to start by framing why I actually think it matters and to think about health, and of course why data are an inextricable part of how we think about health, and how misunderstanding data leads us to make poor decisions on health, leading us to some of the challenges that we actually have with health in this country. I'm going to take a bit of a national focus, but one could equally well do a global focus. So that's broadly my my structure of my talk, and I want to leave plenty of time for questions. So let me start this way, which is, while one might think that the history of health being informed by data is long and rich and productive. In fact, we have, for most of humanity, have been really troubled in terms of our understanding of data that can inform health. We have valued health for thousands of years This is from Heraclitus, who's the father of anatomy, who said, when health is absent, wisdom cannot reveal itself, art cannot manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied, which means health is at the core of all human endeavors. And at some level, you can all take a step back and say, yeah, I get that. I'm sitting in this room because I'm healthy enough to be sitting in this room. Everything, if I had a sandwich today at lunch, I had a sandwich at lunch because I was healthy enough to have a sandwich at lunch, right? So we understand that. And I think humans have understood this for centuries, for millennia, literally. And as a result, humans have sought to understand the world around them by collecting what we call data in order to be able to inform how best to be healthy. Like this has been going on for literally thousands of years. And for thousands of years, we've actually been getting it sort of pretty horribly wrong, actually, which is sort of part of the theme of what I'm discussing. These are pictures from plagues in the 15th, 16th centuries. And on the left, you actually have a picture from London where the plague was attributed to foul odors in cities. And there were sort of data-heavy treatises written about that, which resulted essentially in the rich folk living in villages, because that's where sort of you lived if you were rich, killing poor folks trying to leave cities to come to villages. On the right, you have perhaps, I don't know if it's even worse or it's all terrible, really, the burning of Jews because the data were used to show that Jews were responsible for spreading the plague. So these are examples of actually data being used to advance really ideological perspectives, beliefs, fictional beliefs. But, we say these things about the horrors of the 15th, 16th century. But as I'm going to trace in a second, we keep misunderstanding data and how it affects health for all the way to the present day, okay? This is the Hippocratic sort of framework for what causes health, which is equal parts about blood, equal parts about phlegm, equal parts about yellow and brown bile. That's sort of what this picture represents, which was the data-informed model for the production of human health for about 2,000 years. So I know we're all sitting here, feeling fancy schmancy and saying, well, that's silly. But actually, for the duration of human existence, this is a much more dominant model than, say, is the bacterial model of disease. By the way, some of you may have seen movies and read books about things like bloodletting. The reason bloodletting happened, it wasn't just random. It was because the data suggested that it was an imbalance of blood with the other humors. So as a result, if somebody had a fever, what you had to do is we had to remove blood in order to get the humors in balance. See, a data-driven approach to thinking about the production of health. Bloodletting, leeches, all comes from a data-driven approach. Fast forward to the middle of the 19th century, and let's come to a really important data-driven observation. This gentleman in the top left, that's Ignaz Semmelweis. Ignaz Semmelweis is probably should take credit for advancing human health of millions and billions of people more than anybody else, because he is the reason we wash our hands. Now, Ignaz Semmelweis, the hand washing, comes from this experiment observation that he did. So now you're looking at data, like this is more like, now you're like, okay, I see a graph that's looking more and more like data, right? These are Ignaz's data. He was a Viennese doctor in the middle of the 19th century. He was delivering babies. And he observed that there were two wards, one which was the ward where data are in pink, one the ward where data are in blue. Actually, there were like two different levels of the hospital. And what the graph is the percent of mothers who died of puerperal fever, which is essentially postpartum fever, essentially an infection, okay? Which was quite high. If you look at the axis, you see 10%, 15%, really high, like 1 in 10. And this is middle of the 19th century. You have to understand this is before the bacterial theory of disease, right? So this is this notion that everybody in this room understands, and we all believe that there are little organisms, there are little tiny bugs that we don't see, but they actually transmit from one to another, right, and transmit disease. that was as fanciful as saying you're going to go there's going to be a unicorn and a rainbow, right? So he said he observed two wards. The blue ward, you see it's lower rates of postpartum fever. The pink ward, higher rates. What he observed is that the blue ward, it was the moms were being delivered by nurses. The pink ward, they're being delivered by doctors. But what he really observed is that the difference between the two was that at the end of the ward, which I'm calling here pink, doctors were doing autopsies and then going and delivering babies. And he said, the data show, look at this. Maybe something's going on. Look at the data, look at the graph. So I said, we should do something about that. And maybe something's happening between these two places, and we should interrupt that, do something about it. Maybe wash our hands. That was Ignaz Semmelweis' solution emerging from the data, right? He did what we want data to do, to inform, to educate, and to try to make decisions. So what happened when Ignaz Semmelweis put this out there? I mean, this was really a breakthrough. Well, what happened was the medical establishment, now it's epitomized by this gentleman who was one of the leading obstetricians of the day, said doctors are gentlemen and gentlemen's hands are clean. And Ignaz Semmelweis lost his hospital privileges and really died in poverty in what at the time was called an insane asylum, ironically enough, of an infection himself. So we have a history when it comes to health, something that, as I noted in my opening quote, we care about deeply. We have spent centuries trying to attribute causes that generate health. And in those centuries of attribution, we've often gotten it wrong. And fast forward to today. So you're sitting here thinking, well, we're doing Love Data Week. We love data. All is good. So surely we have it much better now. Well, do we? So let's talk about health in this country. As I said, I'm focusing here on this country, but one can talk more globally. So in this country, our health by any measure is terrible. So this is preventable deaths over a 20-year period. The blue line is other high-income countries. The green line is us. The spike here is COVID, but ignore that. So you see, we are consistently have more deaths that we could prevent than other high-income countries. You can look at treatable deaths we could treat, many more than other high-income countries. And this is true for any number of hospitalization, congestive heart failure, diabetes, asthma. We're not higher on chronic pulmonary disease because we smoke less. We'll come back to that in a second. And as a result, our life expectancy, this is us, this is other high-income countries. The dip again is COVID, but leaving COVID aside, we essentially give up about 5 years of life expectancy compared to other high-income countries. This is us in a country where we use data all the time and where we use data towards informing how we think about health. Not just that, we also, in health, leave many people behind. We actually have a system where many people have far less of the asset that one might call health than others. We can look at that at the state level, for example. These are different states. This looks at difference in life expectancy. It's about a 7-year difference in life expectancies between the states with the highest life expectancy and the states with the lowest life expectancy. In counties that are adjacent to one another, we have about a 20-year difference in life expectancy. See, the red county is about 66. The blue county is about 87. It's about 19-year difference, red counties, blue counties. So there's enormous gaps. We have gaps between groups defined by any number of measures of identity. We can look at racial identity. These are Black Americans versus white Americans, with Black Americans are in blue, white Americans in red. High blood pressure, higher among Black Americans at all ages. Diabetes, higher among Black Americans than white Americans at all ages. And as defined by other characteristics, this is, for example, by income. So this looks at the highest resource 20% of Americans, essentially the richest 20% of Americans. This looks at the poorest 80% of Americans, essentially everybody else. Over time, this is angina, which is chest pain, heart attack. You see, it's going down for everybody over time, but you see how the gap is widening between the between the higher income and the lower income. And by lower income, by the way, I mean 80% of the country. I just want to be clear, right? And you see how that gap has been widening over the past 20 years. Now, you say, And I know where one's mind goes to when I think about something like this. You're like, okay, well, because people maybe don't have enough healthcare, right? That's instantly where we go to when we're thinking. But a lot of this is much more complicated than that. This is the inverse care law, which was articulated by this gentleman, Julian Tudor Hart, exactly 55 years ago, who said the availability of medical care tends to vary inversely with the need for it in the population served. And we do this over and over again. Even though we know where the population served is, we offer more medical care to populations that need less care. I'll show you that as a concrete example. This looks at vaccines, COVID vaccines. The bubbles are US counties. The top row are the counties that were most vulnerable with the sickest people. The bottom row counties least vulnerable with the least sick people. The bubbles are percent vaccinated. So you see more people vaccinated here than there are there. More vaccinated but the least vulnerable than there are in the most vulnerable. And to show you one really obvious example, something that we've talked a lot lately, particularly talked about in university communities because of the growing report of poor mental health among young people. This looks at mental health service use and disadvantage. These are the poorest areas to the richest areas. So poor to rich. The blue line is the use of services. The red line is the burden of poor mental health. Here it's measured by something called the K10. So what you see is in the poorest areas, worse mental health, fewer services. You go to the richest areas, less bad mental health, more service use. You see that? So although we have the data, right? We have the data. We have this mismatch, this inverse care, where we're offering more services where they are needed less. Now, you might say, okay, well, maybe it's because, we don't care so much about this. Maybe it's because we don't spend enough money on this problem. Maybe, because if we just threw more money at it, we will fix this. True? Not so much. This is our spending in GDP. It was, when this was done, it was 17.6. The data just came out from this year. US health is the biggest industry in this country now. It's 18.3% of GDP. So just in case, for all the students in the room, it's a good career because there's a lot of money going in it. And we spend more money than all other high-income countries. These are other high-income countries. This is us, you see. We spend more money than them. And when you combine how much money we spend and our life expectancy, these are other high-income countries. They spend more money. They get more life expectancy. This is us. We spend more money. And we're out here in terms of money spending. And you see we're lower in life expectancy by about 4 years than everybody else. So the problem really is not that we're spending less money. Now you might say, okay, I know the problem. The problem is COVID. COVID, I heard about COVID, bad thing. We didn't do very well. It must be COVID. Not really the problem either. This is, again, us compared to a few other high-income countries. This is with COVID, and this is our life expectancy compared to them. But this here subtracts COVID. So this now removes the COVID data. And what you see is we're still worse, and we still have doing worse in life expectancy now in the past couple of years than are these other high-income countries. So we have the data to show what is going on, and yet, what we are achieving is less than do other countries. So now we come to why. So what is going on? And this brings us what I think is at the heart of a week like Love Data Week, which is trying to think about how one uses data. Because, I started us off from 2,000 years ago, and it's easy to scoff and say, we thought, look, how cute. We thought it was phlegm and blood and bile, it's fine. But we didn't really have good data. Then you move to the Middle Ages, and you're like, we didn't really have good data. Then you move to the 19th century. You're like, yeah, we had data, but we really weren't so confident about the data. Now you move to today, we don't really have an excuse. Like, we have a lot of data. There's a bunch of data around. But what I think emerges when you think about this history is that we have a mismatch between our empiric use of data and our understanding of the data and our ability to make the data give us meaning. So we can actually understand what we should be studying and how that should be guiding us to decide on our actions. And those are really quite different things because the data by itself are just inert quantifications of the world around us. How we then interpret that and what we take from it is really a much higher order and much harder problem. And while I realize when you invite someone like me to speak here, I'm going to talk about health, I would argue actually health is a good example of this because health matters and it is concrete. And we in a university, like in the citadel of eggheads, it's easy for us to get lost in the beauty of data, and there's a lot of beauty in data, and to forget that unless the data are interpreted properly, they are not achieving the outcomes that society would like to achieve. And I argue that is exactly what's happening in health, and that is what has happened in health for many centuries and millennia. So let me come to now, so why is this? So what is this misinterpretation in health? I use the story often to talk about what generates health. This man, his name was Blind Willie Johnson. Blind Willie Johnson is remembered as one of the fathers of the blues. The blues are really one of the quintessential American forms of music. Willie Johnson was born in Texas around the turn of the 20th century. So born around 1900. He was born sighted. He lost his eyesight at age 7 in a domestic violence incident. He grew up poor, Black, blind in Texas in the early 1900s. He faced racism, exclusion from a lot of social structures. He was homeless for a good part of his life. He was married. In the early 40s, he developed malaria. Now, in the 1940s in Texas, malaria was quite common. In fact, the CDC, the Centers for Disease Control and Prevention, which until recently was the world's premier public health organization, was started as a way of transitioning the malarial control program into a national public health program. His wife took him to hospital where there was treatment for malaria, chloroquine, informed by the data, but he was turned away from hospital. Unclear if he was turned away because he was poor, because he was Black, or because he was blind. And then he died. So the data had been used to create the medications that were available to Blind Willie Johnson, chloroquine. His wife took him to hospital, and he still died. So why am I telling you the story? I tell you the story because we cannot understand health without understanding the full picture of what generates health. And the Blind Willie Johnson story tells you everything you need to know about it. That right there is a PhD in population health. Because you understand that you can have all the chloroquine in the world in that hospital, behind that door. If I have malaria and I can't access it, it's not going to help me. You understand that what drove his health was as much his skin color, his poverty, his blindness, systems that excluded him, structural racism. All of these were the forces that ultimately drove his health. And unless we use the data to understand all these forces, together with the data that allows us to understand how a pathogen can be affected by and treated by a drug, we are not going to improve health. Now, I'm telling you the story because stories are memorable, but I can show you this in infographics. I can show you this in data. This is an infographic, sort of more or less used in the field from the Center for Clinical Systems Improvement. Healthcare really contributes to about 20% of health. Smoking, diet, alcohol use, sexual activity, where we live, our education, our job status, our family support, our income, our community safety contribute to the rest. So if we are spending all the money we're spending on health, it is only rational that we should be spending our money proportional to what's causing health. And if we don't, what's going to happen is we're going to be underperforming on health. In much the same way as we've been underperforming on health, misunderstanding the data for centuries, right? Remember I said we spend, how much money we spend? About 18% of health is now about $4.3 trillion. About 3% of that spend is actually about trying to prevent disease. Now, let me ask you this question. Two worlds, world A and world B. World A is a world where you never get Alzheimer's. World B, a world where you do get Alzheimer's and there's a treatment for it. Who would like to live in world A? I mean, nobody ever wants to live in world B. Of course not. But you see how our understanding of the world we want is different than what we're actually doing about it. You see how I started off with a 2,000-year-old quote about the importance of health, how without health we have nothing. And I suspect that's probably not that different than how we feel today. But we are still putting our efforts in a place where it is misaligned with the values that we hold, and that is only partially informed by the full set of data. So I suppose what I want to do in this keynote is to try to give us, coming from a health lens, that's just the world I live in, a lens about how one uses data, and recognizing that data tell us a story that is going to be effective if we want to be careful about how it's used. Otherwise, we are underusing it and not using it right. And there are real consequences to not using it right, because the people have noticed. Now, what do I mean by that? Well, you may have heard of the Make America Healthy Again movement. This is the MAHA report. This is the MAHA report, which I would encourage everybody to read. The Make America Healthy Again report, the very first figure in the MAHA report is this. Does it look familiar? It's exactly the figure I showed you, right? It's just different colors, but it's exactly the figure. See how we're spending on health, life expectancy, that's us. Those are all the other countries. It's exactly the same figure. So at some point, the people notice these problems, and the people create approaches that are trying to push back at the dominant prevailing paradigm. Now, that pushback may contain in and of itself its own misdirections and its own challenges to health, but I'm putting that aside for a second. The point is that the pushback is informed by observations about the world and recognizing that our read of the data is misaligning with what we are doing to create the outcome that ostensibly we seek, which is better health. And by the way, in case you thought that the sort of MAHA movement is some sort of fringe movement, about 40% of parents subscribe to the MAHA movement today. That's about, it's about 4 out of 10, 2 out of 5 people. That's a lot of people. That is not a movement that one can or should dismiss. That is a large number of people that, whether we like it or not, being where we are in universities, we have to grapple with. So, I guess this is the heart of my talk, which is fundamentally better data can lead to a healthier, more equitable world, and better data understood properly through the lens of what it is that we're trying to measure. I had the privilege about 4 years ago of leading this global commission. It was called Data, Social Determinants, and Better Decision-Making for Health, for short, the 3D Commission, Data Determines Decision-Making. It was sponsored by a couple of large organizations, and we convened a large number of commissioners globally to really try to tackle this problem. Try to tackle the problem of how do we think about data in the context of generating health. And the report, which is available online, you can look at it, but I just want to highlight a couple of things. So first of all, you cannot really understand health without understanding the full set of data, where you deal with politics and governance and economic policies, how they affect things like social cohesion, how that affects your networks, your assets, your income, how that affects your behavior, and how that becomes encrypted under the skin, and that becomes health. All of that accumulates over the life course, and none of this actually is fully interpretable without thinking about the emotions, the values, the historical legacies, and the luck that situates us in particular moments in time, places in time. So if we are to understand human health, we need data on all of this. And our job is to be clever about how to integrate these data, which of course come from multiple sources, to create a better understanding. And the point is, and I don't want to at this point lose what I'm hoping is the lesson that everybody extracted from the blind Willie Johnson story. Because what we keep doing over and over again as a society, I tell you the blind Willie Johnson story and you say, yeah, I get it. But you know what? Structural racism is really hard to deal with. Homelessness is hard to deal with. Domestic violence is hard to deal with. So what we're going to do is we're going to spend all our money on better chloroquine. What I hope that that story shows is that if we spend all our money on better chloroquine, blind Willie Johnson is never going to get better, right? We actually don't have a choice but to spend our money and focus on data that looks at the whole picture. And that is counterintuitive to what we tend to do, because our efforts tend to be, let us focus on the one thing we can do. I don't know if people know the lamppost bias. Anybody know lamppost bias? Lamppost bias, somebody's on their knees in the dark under a lamppost at night. Somebody else walks by and says, what are you doing? The first person says, I'm looking for my keys. And the other person says, okay, I'll help you. They both rummage around under the lamppost looking for their keys. No keys for a few minutes. The second person says, did you lose your keys over here? The first person, no, I lost them over there. The first person says, well, why are you looking here? Well, this is where the light is, right? So this is a problem that we do all the time because we look for things in data where it's easy for us to look and ignore, admittedly, harder, more complex pictures. So what does this mean for data? Well, it actually means that one needs to think about collecting data in different ways. So this is a complicated, but I'll just lead you through it. It's like, one can have multiple data sources. You can have traditional data sources. If you look at the bottom, you see things like health assessments, medical records, surveys, vital records, census. These we call the traditional data sources, okay? You can think about newer fangled data sources, digital consumer footprints, EMRs, mobile phones, remote sensing, and we can take all of these as a piece. Or we can actually think of all of this as an interconnected web that describes the full interaction that we as humans have with the world around us, that ultimately shapes who we are, how we think, how we behave, the food we eat, the water to drink, the air we breathe, our interpersonal interactions, how policy choices affect how safe we are or not safe we are. And that is what is going to give us a fuller understanding of what ultimately generates health. Now, this report came out, about 2.5 years ago. It was about a 2-year effort. So it's before actually the enormous surge of artificial intelligence capabilities to the broader public. Of course, capabilities have been around for decades for those who are in the know, but for those of us who are end users, this could be transformative in terms of thinking about creating those kind of interconnected webs of understanding the universe to fully capture the world blind Willie Johnson is navigating, to be able to understand what are the key levers that we can press to improve his health. And obviously, I think everybody understands, I'm using blind Willie Johnson as a metaphor for all of us here. Doing this requires, we discuss in this report that you cannot really think this way without recognizing that we need to somehow integrate decision-making processes in a way that reduces competition for space between data inputs. So what this figure is showing is you have sort of competing priorities. You have social factors, new data sources, traditional data sources. The way that the decision-making typically happens is all of these are coming at a decision maker, and the decision maker is overwhelmed, often, by the way, has very limited understanding of any of these data sources, let alone all of them going together. So you go through a funnel, and then whichever data point happens to make it through is what we act on. So to go back to blind Willie Johnson, if the decision maker is the biomedical system, all the money is going to go into chloroquine. If the decision maker happens to have the data point about homelessness, they're going to say, that's the problem. I'm going to put all our money into homelessness. If the decision maker happens to recognize that the problem is domestic violence, that's what we need to fix. And of course, you all realize now that any one of those in and of itself, by definition, is going to be insufficient. And I could show you more sort of sophisticated mathematical approaches that actually make it clear that in a universe where you have co-occurring causes, the prevalence of any co-occurring cause is going to bind how much you can actually achieve action by dealing with the other cause, that you fundamentally need to work with both these causes, let alone when you have multiple causes. And that is a difficult world to envision. You know, in the report, we talk about fundamentally, you need to get to this kind of environment. And this is actually why I find the moment that we're in with the surge in artificial intelligence, generative artificial intelligence potential, actually exciting, because I think there is potential here, if done right, to create an integrative approach to multiple data inputs that really describes health and its production much better than we have before, that potentially can move us beyond this funnel where we make decisions on individual data points, which represent only a small part of the universe, and pushes us into continuing to make mistakes that has us under-delivering on health year after year after year. There are a few principles that emerge from the report, which I just want to talk about for a second. And because if you're thinking about data in the real world, helping you make meaningful decisions, there are guardrails around data that you want to put in place. There are ways in which you want to make sure that the data are used responsibly. And the report tries to spend time discussing that. You know, it is one thing to think about data, again, in the abstract, as this wonderful, beautiful thing. It's a forest of shiny lights, and that's great. But if we're thinking about data in the context of it being meaningful, to generate something that is as meaningful to us as humans as is our health, we need to be conscious of the harm that data can do, so we can maximize the good that data can do. So the principles include that evidence-informed decision-making needs to incorporate data from across sectors. I've talked about that. All decisions that are made need to recognize that there are going to be consequences to our health. Number three, we need to make sure that we use data in a way that doesn't leave people behind, that health equity is at the heart of how we think about data. Number four is we need to make sure that all data resources are kept in mind, that we're not blind to forces that we know matter just because our ability to measure them might be worse or might be weaker. Number five, we should be transparent and accountable about data and the data we collect. And number six, we need to make sure that we include diverse perspectives on data, because data, as I know you've covered in other sessions in this Love Data Week, you know, data are, while we like to think about data as being dispassionate, there is not a single data source in the world that doesn't get interpreted through the lens of our biases, our perspectives, our preconceived notions as humans. And that means that in order to be able to deal with something as important, as valuable, as core to our human identity as is our health, we need to make sure that we balance different perspectives on how we are interpreting those data. Because when you go back to the Blind Willie Johnson story, the data point that says, we just flood the world with chloroquine, he's going to be fine, is a far world from the reality that he is living in. It is a far world from a reality where one needs to make sure you break down all sorts of barriers for him to be able to get the drug. And the report also came up with a set of recommendations around fundamentally implementing real-time quality data at national and global levels that are transparent, that can be used to hold national and global governance accountable by using health as a metric. It's almost quaint to see this 2.5 years later, how far the world has come from that point, not necessarily for the better, but it was a time of idealism. And you know, to, I think, the credit of the sort of the work that the commission had done, you know, centered in all this was trust. You know, everybody now talking about trust. Actually, 3 years ago, we really weren't talking about trust. This was like front and center though in the commission's report. We said, you actually don't have communities trust you unless they see that you are looking at data in a way that bridges the gap between the abstract and the concrete outcome you want to get. You need political will, you need to be technically good, you need to engage communities And that is what makes you trustworthy. And that is what buys you credence with the community, that you can take data and do good with it. So let me wind down. So I talked about health, and yeah, I think it's reasonable for, many of you in this room probably aren't, health is not what you're actually spending your time in. That's fine. But I do want to point out that while my niche, my lane is health, it is hard to avoid the observation that health is inextricably linked with a lot of larger forces in the world around us today. That a lot of the swirl in this unsettling time we are living in has at its core human dissatisfaction with fundamental states of well-being, a lot of which reflects underlying human health. I'll show you a couple of slides on that. This is a 20-year period in mortality. So this is the y-axis is mortality. The lower you are, the less mortality. The lower you are, the healthier. Between Republican counties, voting counties, and Democrat voting counties in this country. Right? It's quite remarkable. There's quite a remarkable gap that's been growing in the past 20 years. So we talk a lot about the divisions in this country. We talk a lot about the breakdown in trust. We talk a lot about how red America cannot talk to blue America. And there's many reasons for it, but I feel like we don't talk anywhere near enough about the fact that, I don't know, I think if you're in the red counties, you might resent the blue counties. Why are they so much healthier? And these observations have implications for what happens in our elections, which of course has implications for everything. This graph is about a consequential election. This was 2016, when candidate Hillary Clinton was running against candidate Donald Trump. There were two candidates. There are many forces that happened in that election. But one of the forces was, one of the candidates was the candidate of the establishment, who had served as Secretary of State, who essentially, when a candidate of the establishment, you don't really have a choice, but say, things are going well, I can make them better, vote for me. The other candidate was a populist insurgent who said, everything's going to hell in a handbasket, vote for me and I'll rip up the playbook, right? So on the x-axis, you have this by county, the bubbles are counties. On the right of it are improvement in county health over a 40-year period. On the left, county health staying the same or even getting worse. The y-axis is percent of the vote for candidate Donald Trump. And what you see is a very clear dose-response relationship. Healthier the county, less vote for candidate Donald Trump. And lest you think that we are overly special as a country, there are actually data, although not as good as this, that show this phenomenon in other places. These are European data. Ignore this. It shows the same thing, but this fundamentally shows it. Good health, very good health, bad health, percent vote for the populist insurgent. You see, when your health is worse, you're voting more for the populist insurgent. And I think this gets back to the fundamental premise I made in the beginning, the Heraclitus quote, which is health is at the heart of all we do. I mean, raise your hand if you have a day when you're feeling sick and unwell and you walk around smiling in a good mood, right? Somebody is. This affects everything we do. And while I'm here, my charge is to talk about data and how to make data meaningful in terms of thinking about health. I couldn't resist sort of framing this that, yes, that is my lane. But ultimately, this matters for all sorts of things about the world around us. And we need to recognize an extension of what I'm saying is that us wielding data well, understanding how the world produces our health and well-being, our ability to flourish, is a way to build a world where people make rational political choices, not a world where we are creating plenty of reason for a large part of the country to feel rejected by another large part of the country and to make decisions that then have consequences that hurt all of us. So I'm going to stop there. I think a lot of this is about learning from and improving the past. This is a slide about, it's hard to break out of the prevailing paradigm. Preacher on the right is a kangaroo. You're all looking at that and you're saying, that's not a kangaroo. Well, yeah, but you're all fancy pants. You've seen kangaroos. Well, the guy who drew that, Cornelis de Hooy, in the 17th century, had never seen a kangaroo. He was a Dutch painter, but he talked to Dutch sailors who did see kangaroos. And they came back and they said to him, there's this fearsome creature. It's got a long neck, carries the baby in a pouch. It's got strong arms. And he painted what they told him. That was the prevailing paradigm until, of course, we had pictures and we had trips. We could go see a kangaroos. So I think data are like that. They tell us pictures. And if we see the wrong picture, we make the wrong decisions. And we underperform on things that really matter, like our health. And our job, certainly our job in universities, is to do better than that, is to be smart and thoughtful about the data collection, the data analysis, its interpretation, the biases that go into it, how we think about data holistically to be able to understand what really matters to the social ends that really matter for all of us. Well, and with this, initially it seems silly, then it seems controversial, then it seems progressive, and then it seems obvious. I'm not sure exactly where this is along that spectrum, probably a little bit of all of it at different times, but it is always when I speak in groups like this, my hope that the next generation, which many of you in this room are, will be better. Thank you for doing just that. If anybody's interested, this is a blog that I do every week or other week, which sort of extends a number of these thoughts. I'll take questions. Thank you.
Okay.
Yes,
It's very powerful.
it is.
Thank you very much. I have a probably very basic question, but I can't help but be curious in that graph where we looked at life expectancy and money expenditure for health. What qualifies as an expenditure for health?
It's the same thing that I showed you in the other graph, which is where I showed you 3% of it is actually used for preventive services, but essentially all the money that other countries, but I'm showing multiple countries, spend on health. So it's in different countries, it lives in different departments, but it is hospital care, drugs, transportation to health services, efforts around prevention, public health, all of it, the whole thing.
Yeah, I was curious from just a cultural standpoint of gyms memberships.
Yeah, no, gyms would not, no.
Nothing retail-y.
No, nothing retail-y, no. Well, except a lot of health care in America is retail-y, but yes. But no gyms.
I have a question that I think you're going to decline to answer, so I'll give you a second softball question that you can answer.
With that introduction, I'm keen.
I know you're not a fortune teller, but if you had to make a prediction about what is the ridiculous that soon will be obvious, what is it today that in the future we will look back on and think is obvious? And if you don't like that question, what gives you hope?
Well, I think my answer to both questions is the same answer. I think Hans Rosling, who was a data scientist, Swedish, who passed away, used to say, the world's a terrible place. The world can be so much better. The world is better than it's ever been. And I think those three capture it really well. I think the world's a terrible place. I think the world can and should be so much better. That's what motivates me every day. But I also think the world is much better than it's ever been on many dimensions. And, there are bad days and bad years, and we take a step forward. Sometimes we take a step back. But, we are better today than we were when we were leeching people and bleeding people. We should not forget that. I speak about how much better we can be in health in this country's context. And I didn't talk globally. One could talk globally as well. But I say that perhaps from a place of belief that we can be better. So that's why I'm saying I think my answer to both is exactly the same. I actually do think it is frustrating how much better we can be, while at the same time, it is heartening and gives hope how much better we are than we were 50 years ago. Would I like to see our slope of betterness accelerate? Absolutely. And I see that as my job to try to encourage us, all of us, to steepen our slope of betterness. And I think that's our job, all of us in universities.
Thank you. It was very enlightening. I'm curious, when we're talking about structures, for the United States, a lot of people, their healthcare is tied to their employment because their insurance comes from their employer. And so is there when we kind of tease apart the data of countries where it's, a Medicare for all sort of model versus something where another structure is your dependency for your health care, do we see differences there or kind of?
Yeah, it's a super complex problem because yeah, I'll show you. There's a couple of other data points which I didn't give you here. So if you are to be sick and you are to be admitted to a hospital, you should choose to be admitted to an American hospital versus any other high-income country hospital, because on aggregate, you are going to do better in an American hospital. Like once you're actually in the hospital, to go back to my blind Willie Johnson metaphor, once you're actually in the hospital, you're getting chloroquine, you're going to do better than in most other high-income countries. There's a lot of heterogeneity there. So I'm not saying every hospital everywhere in the country, okay? So there is no question that paradoxically in this country, we have worse and patchier access to care than essentially all other high-income countries. But once care is accessed, that care is actually very good. We can discuss the rationality, but I'm just telling you how it is. So if we had more uniform access to care in this country, would that be a good thing? Absolutely, because care as then provided is a good thing. It's not as simple as saying, can we just do a regression with countries with universal access versus countries without universal access? Because the countries without, they're so different demographically, they have so different other underlying forces. There's so many unmeasured, now I'm sort of getting technical speak, unmeasured confounders, which sort of map all what I'm showing you. But in this country, there is this paradox of good care if you can get it, very patchy as to whether you get it or not, and the who gets it and not is intimately intertwined with all the other forces in the world around us, which probably matter more for your health than does the care itself. That's the complicated picture.
Sandro, I'm curious, what do you see as the biggest missed opportunity and how we currently use data to improve lives?
Yeah, I think thank you for the question. I actually think the biggest missed opportunity is actually what I mentioned here. It's like, I mean, I suspect, when I say this, a number of you are like thinking, well, it's sort of obvious, it's like intuitive, but we don't act as a country like it's intuitive. Like I don't think I'm saying anything. I don't think that is hard to wrap your brain around. It's like I've given talks, sort of multiple audiences, some quite ideologically different than I am, and they're like, yeah, okay, we get it. It's but there have been forces deeply ingrained in this culture, in our political, commercial structures that make it very hard to break down. So I think that's the biggest opportunity loss, and also the biggest opportunity. And to just to go for a second to just make a comment about the Make America Healthy Again report. To be at a point in the country's history where there's a dominant movement called Make America Healthy Again is a really good thing. It's good. It's actually good to have the public focus on making America healthy again. If we can actually extract the good from that and remove the good from some of the very tangible, harmful pillars of the Make America Healthy Again movement, the country could emerge in a really good place.
Thank you, Dean Galea. I'm reflecting on the kind of duality of that expenditures to life expectancy chart that you showed in the Maha report. And it makes me think of how universities are variously keepers of data and also jailers of data. And I'm curious if maybe you could give us your reflections on how we can be better making data accessible, but also insightful for people.
Yeah. Yeah, no, it's a super question. Look, I think universities have three roles. Good news, only three roles. Number one is to generate research and scholarship. Number two is to educate students. And number three is to have a part in translating that knowledge to the end of advancing society. And I'm using general words intentionally. Now, you might say, why does number 3 there? Well, universities, if for no other reason, are not-for-profit institutions, which means societies invest in them, and it's not unreasonable for societies to expect a return. And part of that return is us translating that knowledge to create a better world. So I say that because I think this gets at your point, which is universities are creators of data. And I think we're doing the wrong thing if we are being jailers of data. Now, I don't disagree with you that we are. I mean, today, had a privilege this morning being part of a symposium that we organized where the keynote speaker did a very nice job, and she was talking about some of the barriers to access of data that in universities we take for granted in general public. And she was using, for example, the example of academic journals and the fact that many articles are paywalled. And it's a very good example. And I'm sitting there in the audience. I'm in agreement with her completely. And at the same time, I'm actually the editor of a reasonably large journal. And I'm like, I know the financial model, and I don't know how else to make it work. So it's like at a level of concept and principle, I'm like, yes, we should fix that. At the level of pragmatics, that is embedded within such a complex system that it's hard to know how to separate it. So one could despair and say, we're never going to solve this. Or one could say, world is a terrible place, but it's much better and it will get better. I don't know what the solution to some of these problems are, but this goes back to hope. My hope is that you'll figure some of them out. I don't think you're going to figure them all out. Maybe you will, but if you just figure 1 or 2 out, the world will be a better place.
Yeah.
Time to get moving because, you know, it's a big agenda. This one in the middle, yes.
I'll be quick. I kind of have written it down so I don't say anything wrong. Firstly, thank you for sharing. And but like we as an institution, we keep collecting data. So, but where do we find the balance where we collect the data and also kind of make sure that the voices of communities that are underrepresented, they're not missing from the data sets or they don't often get neglected. So where do we find that balance of kind of, advancing the analytics, but also translating insights into like community level action?
Yeah, and I think this is in some respect an extension of the question from the back, which is, right, it is about our responsibility to use data for good. And by us, in this case, I actually mean within universities. And part of the responsibility is to use data accountably, transparently, and inclusively. Again, it's easy to say those words, much harder to figure out how to do it. And I think, I worry about us, sort of flinging around, performative 4-syllable words about how we can, be engaging and inclusive. Without really asking in the real world, away from the performance of social media, what does that look like? And, I think it looks like having real engagement with communities' commitment to that. I mean, this university a few years ago said to itself, look, we are a university in a city where we have not explicitly focused on trying to give back. Let's now try to focus on giving back through in St. Louis for St. Louis, in a university which said, we're having a school of public health that has as its mission an approach to crossing disciplines and to engage in local and global impact is a way of us giving back, and the university making that kind of investment. And I think that is good. That is noteworthy, and I think this university should take credit for that. And these things, these things take time. It actually does take time to change paradigms and to change how we're doing things, to change from, seeing the kangaroo as that sort of, magical creature to actually seeing what a kangaroo actually looks like. But I don't know, if you all spend an hour on a Tuesday afternoon listening to a talk like this, that gives me hope. So thank you. And thank you, Nancy, for inviting me.